Good rising, good afternoon, good evening, or good night. Let me turn this up a little bit. Ooh, you can hear me? Reg?
Yes, I can hear you.
Okay. Okay. Let me know when you're all set.
Okay.
It's not Friday, but put it on your lip. The closer you are, the clearer it is.
Okay, yes, on my left.
All right, and the less typing that you do on your computer, the less sounds that we'll get.
No typing going on. Date.
14th. Okay. And you know I butcher names. Y'all know I butcher names. Mbaike. Oh my, just say it.
Okay, let me make it easier. Mba.
Mba.
Wu, like Wu-Tang.
Wu-Tang. Mba wu.
Ike.
Ike. Mba wike.
Like tastes good?
Ba.
Mbawe, mbawe, bawe. Remember that song?
Yes.
Mba.
Mba.
Wu, like Wu-Tang.
Wu.
Ike.
Ike. Mba wu ike. I wish I could just say it all together.
You can read it. It reads exactly.
Mba wike.
Exactly.
Mba wike. Okay.
Exactly.
Good rising, good afternoon, good evening, or good night. Waking up with Taylor Andre has absolutely nothing to do with the time of day that we link up, but about waking up your third eye with unorthodox conversations leading to universal consciousness. And today we have an extremely unorthodox conversation because I never thought in a million years that we will be discussing black women mortality rates in the United States of America. We have here with us today Reginald Umbawike, who is a Harvard fellow. He is a research graduate or research grad. And we're going to be discussing today about black women's mortality rates in the United States. Now, I thought this was a topic or a subject that we would be discussing regarding third world countries or somewhere in Africa or somewhere in the Pacific Ocean on an island where doctors aren't without borders. But in the United States of America, there is an epidemic of black women dying during childbirth. Good afternoon, good rising, good evening, or good night. Reginald, how are you?
I am doing good. Thank you for having me. It's an honor to come here today and speak on this very important issue and talk about what the community as a whole can do to come together to combat this significant health disparity involving black women dying during childbirth.
So, for me, this is... Help me understand what these numbers look like. So, in the United States, what are these current numbers versus numbers in, let's say, in Congo or in a third world country?
Well, first and foremost, in several countries around the world, we have, very significant issues, war raging, and et cetera, et cetera. In Nigeria, for example, we have one of the worst infant mortality rates in the world, where for every 100,000 childbirths, 88 women die during childbirth. That is very bad.
That sounds like a low number, though. Out of 100,000, 88 die.
On a simple procedure of a child coming
Giving
out.
birth.
So when you look at the United States, for example, the United States has the worst maternal and infant mortality rate in the developed world. So from all the countries in Europe, Canada, Japan, etc., America has the worst maternal mortality rate. What we have is in between the years 1979 and 1986, for every 100 100,000 childbirths in America, we had 9.1 maternal deaths. This rose rapidly. By the year 2000, it became 14 deaths per 100,000 childbirths. And by 2013, it rose to 18.5 deaths per 100,000 live childbirths in America. Now, that is for America as a whole. Sad and depressing thing is that the rate for black women maternal deaths in America is times 3 that. So we're talking 3 times 18.5 deaths per 100,000 childbirths, which is horrendous.
So I'm not really good with numbers, but it sounds as if back in the 70s to the 80s, it was 9 deaths per 100,000.
Yes.
Then it rose to 18 deaths per 100,000. But we have more medicine, more knowledge, more understanding now than we did back in the 70s and 80s. Do we know the cause for this increase when we've developed ourselves more in healthcare, but yet the numbers are increasing?
So that is the puzzling thing here. When I speak to folks in different professions and areas, they ask, so why? What is the reason? As if we can pull the reason out of a hat. When we're looking overall, before we get to black women, when we're just looking at America as a whole, how a country this developed with all the best pharmaceutical firms, the best hospitals, etc., has the worst maternal mortality rates in the developed world. That's a big issue. When we look specifically on how, even with those worst rates, how it's 300 times more likely for a black woman to die at childbirth, then we have very significant reasons to look at the reasons. And what I'm saying is that we have not been. We have not in this country.
We have not been looking at reasons.
We have not shown the propensity to face this very significant issue with the vigor necessary to amend the problems.
I'm perplexed because I'm not understanding. I'm not understanding, how when we had less knowledge, we had less deaths. And now that we have more knowledge, we're having more deaths. But yet we don't have any cause. There's no causation for this at all. There's not even a guesstimate. No?
So we have a lot of practitioners, OBGYN, experts who have different theories on this. What we've had is also a lot of time to look at this issue between 1980 and 2013, when the rates doubled. So we have better. Around 1980, if a woman was pregnant, she'd go shopping for clothes for a girl and a boy, because there were no systems back then to tell you what you were going to get, right? Now you just go and
get an ultrasound and you know if you're having a boy or girl.
Exactly. So there are those systems and technologies that you would think could also, with all that technology, is find out a boy or girl. You should also be able to find out whether there are complications for the health of the woman bearing the child.
I thought they did, though, because I thought that don't at some point, like your 4th or 5th month, they do like an amniotic fluid, a huge needle that they stick in your stomach, and they're able to tell whether or not the child has Down syndrome, if there's any other, genetic.
There we go. There are several advances that have gone to assess the potential health of the born child.
But nothing for the mother.
Whether she might even make it to see that born child have all those either healthy or unhealthy issues.
So do we have the number of how many women in the United States in the last year, like 2014 to 15? Because I know, like, research, do we have that number of how many women in total have died in childbirth?
I don't have that number with me, no.
But we do know that it's 9 for every 100,000. Yet in the Black community, it's 36.
It's 18.5 for every 100,000. So let's just say 19. So that'll be 19 times 3.
So 30. No, 60.
Yeah.
Like roughly.
Like 56 Black women die in America per every 100,000 childbirths, and the worst rate in the world is around 88.
And that is?
That's Nigeria and countries like that. So among the worst in the world, the United States of America.
So, all right, let's say, for instance, is it because they live in rural areas and they don't have access to medical facilities? Or is it because they decided to go with a doula instead of going to the hospital? Is it, do we know those numbers? Do we know the women that have died during childbirth that refused to go to the hospital or didn't have access to the hospital versus the women who actually passed away in the hospital?
Yeah. So what I'll say is that there are several indications from several different things, like some of the things you just asked, that highlight possibilities of what the sources could be. Currently, we have not, as a country, as the medical society in the United States, honed in on what they are. So what we're doing at Harvard University
in 2017,
yes,
you can't tell me statistically the number of women that decided not to go to the hospital versus, like, the thing that frustrates me is, as a scientist,
yes,
I don't know if statistics has a statistical, like, you have these numbers,
yeah,
but yet we don't have any answers.
Yeah.
It's 2017 and you can't tell me, well, XYZ women passed away outside of the hospital versus XYZ amount of women that passed inside a hospital. We don't even have those numbers.
I'm not saying we don't have them. It would be very interesting to find a research study that has conducted that currently, maybe for 2016. The year is not over. Usually after the year we look at the bypasses, and we'll look at the numbers in that case. We'll look at how many women choose to have home births. From those home births, how many deaths we have from home births. Then of those home births, what are the demographics in each of those births? And of those demographics, who lived and who died.
But as of now, we don't know of those studies.
As of now, I am not certain what those studies are or have shown.
Well, I am certain that you have done your due diligence, because I know you well enough to know that's not something that you skip over. And
what we're really talking about, though, is that including hospitals, right? In hospitals, from medical professionals, there are several things we're looking at as to indicate or find indications on, what pre-birth could be. We can find signals, and then what post-birth is taking place from, pulmonary artery, illnesses, or that take place after childbirth. How do you find them? How do you identify them? How do you limit them? How do you combat them? And then how do you lead to decrease in the deaths due to them? So what we're doing at a group of doctors at Harvard Medical School, from Harvard Medical School, Harvard School of Public Health, put together a program called the Give mHealth program to see how we could use mobile technology to find, to add additional resources to the current resources, because of the necessary need for expanding methods to find solutions to these health disparities. So we're conducting a clinical trial in Africa, where we have people with similar genetic backgrounds, on how to monitor different trimesters and pregnancies remotely to see if we can give black women the power to monitor their own pregnancies and see if we could have some non-invasive research where we give black women apps, pregnant women apps, connect those with doctors, and have them run remote mHealth clinical trials to see if we can find new things to identify, and if we can have digital methods to identify and then maintain health through these sources, because the current sources are not working.
So what does all that mean? So let's say, for instance, I'm pregnant. I have this app on my phone. I'm in Africa because that's where these clinical studies are taking place. What exactly am I reporting? If I'm monitoring myself, I'm not quite sure what it is that you as a doctor, researcher need to know versus what I may be feeling, experiencing. What am I actually sharing?
Okay, so we're searching for indications, right? Here, you would have an app. You'd be a lady in Africa would have an app, and a doctor in America would have the same app on the doctor's side. Now, if you experience any pain or any kind of, pain specifically in your stomach or any kind of illness that you feel like you're not comfortable, the app allows you to place into the app what you're feeling. It's also video, so you can record yourself, and then you can add what you've been eating, your diet has been, what kind of medications you're on, etc. And then the doctor on the other side will see it, be able to indicate it, and follow on.
So I guess I'm confused because I'm wondering how successful can this be? So these clinical trials are taking place currently in Africa, where approximately 88 out of every...
Led by doctors here at Harvard.
Led by doctors here at Harvard. Approximately 88 per every 100,000 women die during pregnancy. So I don't know how to respectfully say that. Are you guys in hopes of one of these women that have the app may be those 88 and using their experience towards the study? Like, how exactly did you choose these women? How do you understand what
I'm looking at you because I'm glad you're asking this question.
Because it seems like a needle in a haystack. It's just like, let's just throw it and see what sticks. Like, how exactly are you choosing these women, and then how are these results valid?
So, when you're conducting clinical trials, you need good client samples, right? So, we had an event called the Give mHealth Global Transformation Forum, where we had doctors from across the globe who are experts in different forms of healthcare come in and speak about using technology to decrease health disparities. And one of the doctors, the doctor of ethics, Dr. Nir Eyal at Harvard Medical School, asked a question. He was speaking and giving his presentation on how do you conduct non-invasive clinical trials? What are the ethics of making sure you have verifiable outcomes that you can, once you conduct the clinical trials, run with and say, these are the solutions. This is what we research. We believe that these are the actual solid results that you could run with. Because you have that rate of 88 deaths per 100,000, we expect that there could be, from this batch of random pregnant women checked.
How many in total?
As of now, the stage we're in now is we're giving this app to people of all genders and all ages in order to first evaluate how this works randomly with people, so that if
And how,
and
like, they're
it's-
going to know if they know how to work the app, if they're
Bingo.
actually going to use the app,
How-
if it's going to be like birth control and you forget to take the app.
all that stuff.
Okay.
So that by the time we give it to pregnant women, we could now see if there are different pain indications and different things from someone who's not pregnant, right? And then we could start sourcing from there.
Because you're also pulling from a country that may have like malaria
There we go.
or I get it
Or
now.
even Ebola.
Okay.
Okay, so we're talking about as many random illnesses that one could get. How could that be monitored? When we go from that, and then we give a pregnant woman who's in those conditions of those issues, are they the reason why these women would, so that we can separate that from the study once we give it to pregnant women?
So would it be successful? Would this study be successful if out of the pool one of them does die? Is that really how science works? Like
And that's why
your
I spoke of,
demise is our
unfortunately, that's why I spoke about the presentation we had at our forum at the Harvard Faculty Club last year, where Dr. Nera Eyal asked this very simple question. If you were conducting a trial where you needed to find whether this drug could cure someone or this method could, and then you know that a patient somewhere is facing an issue where you could call them and fix, but you're not sure if you're doing this because you want to save thousands of lives. So you need to find out if this saves that one life. So that's where the ethics of non-invasive research comes in, because we need to know why women die. Therefore, we need to give this to some women who may die.
I can see how, the ethics guy would be all over this. Whose idea was this?
This is my idea. My name is, once again, Reginald Mbagye, fellow at Harvard University.
Say your name clearer. Make them know your name.
Reginald Mbagye. So what happened was, how this all came about was I was a fellow at Harvard University in the previous decade, working under Dr. Henry Louis Gates for his book African American Lives, and also worked under Professor Michael Porter at the business school. Some of my roles were putting together global investment conferences, and I was fortunate to be called upon by this group of doctors in 2013 called USA Doctors for Africa. These are American doctors who go to Africa for health missions, and they were hosting an event called the African First Ladies Health Summit, where African First Ladies would come to Los Angeles and give a presentation on the illnesses and diseases in their country. So a doctor, very pronounced doctor, many believe he's the greatest brain surgeon in America, Dr. Keith Black, gave a presentation and said, look, we go to Africa for all these health missions. We've been doing this for 8 years. We've been to 3 countries and 6 health missions. We come back more depressed than we were before volunteering our time and money to go to Africa. If we had an app that can allow us to monitor these patients remotely when we come back and connect with these clinics, then we may not need so many traveling doctors. And just like that, the idea, when they say...
Reggie was like, hold on, I got you.
Yeah, that magic moment, the aha moment, that's what I was supposed to call it. So I came back here, connected with some tech experts in New York and Texas and India, and we created the first one, sent it back to Dr. Keith Black to review, and went to Harvard with it, and I was made the mHealth Fellow at Harvard University.
Congrats. I'd like to do a little clap. Yes, Reg. So, really quickly, you came up with this great idea, and now it's being used to monitor pregnant women. Let's say, for instance, the individuals that currently have this app are facing some type of, health issue. How exactly are doctors at Harvard able to help them tens of thousands of miles away? And is there somebody on the other side that they're communicating with to say, listen, I have this patient, they need to come in. From what they've told me, I'm doing a soft diagnosis. This is what it could be. Like, is there any communication going on? Are they kind of left there by themselves and we're just over here monitoring them?
Well, at this moment, what happens? I, became mHealth fellow at Harvard and introduced myself to all the doctors at the School of Social Medicine, School of Public Health, et cetera, et cetera. And I was fortunate to work under the head of clinical trials at Harvard University, and who convinced me that, look, you have great technology and you want to do it for a great reason. But your technology might be greater than your reason. So this app could be used as a one-to-one doctor-to-patient monitoring app, or it could be used for clinical trials that improve populations. Which one do you want to focus on? So we began the clinical trial program.
So potentially, I could be downloading this app in the near future to have a daily relationship with my doctor.
Yes.
That allows me to not run to the emergency room or
Absolutely.
run to the clinic.
That's the aim.
Every time I have a question.
That's the direct aim of the app.
High five, Reg! This is a really big deal.
Thank you.
I didn't understand, like, when you read about it, it's just like, oh, okay. But when you break it down like that, when you become a billionaire, just remember me.
Hey, one of the things behind, I went to business school, went to Babson College. Babson College, is the #1 school for entrepreneurship in the world. I had to plug Babson there. And, I have a lot of colleagues, classmates, et cetera, who, made millions of dollars doing different things. And I have a lot of colleagues from Harvard Business School who made it big on Wall Street and all that stuff. And I wanted to prove something to them, that one can be successful, as successful or more successful in life by being a social entrepreneur and building something that improves human condition and keeping human condition and improving lives for people at the forefront of your business model can, in the long run, improve your own life.
So you didn't come in here for the wealth. You came in here to improve health, and the wealth just will follow. And
hopefully my health as well. Hopefully I'll feel better every day, getting up every day. And it's, it's been quite a road. And the closer you get to the mountaintop, the stronger the wind blows. But you have to keep climbing.
Say that again. That sounds like an African proverb.
I said the closer you get to the mountaintop, the stronger the wind blows. So, but you have to just keep climbing.
You gotta keep climbing. We are currently in the building with Reginald. You know I butcher names. Go ahead, say it.
Mbawike.
Spell it for us.
It's Mbawuike.
Mbawike.
Yes.
I got it. And we are talking about Black women in the United States that face mortality rates that are comparable to third world countries. And it blows my mind because I never thought that mortality rates in America for Black women would be so high when it comes to childbirth. Do you know of our mortality rates, like just pregnancy? Because these are childbirth, so dying during childbirth. But do we know how many women and women of color die during pregnancy itself? Or is that something that you're looking at as well, or is it strictly childbirth itself?
It's something we're looking for as well. What is very interesting is in the last couple of months, many articles from, I think, CNN, the Washington Post, PBS, have been coming out on this issue. We've been working on this issue for the last couple of years. It is good to see some of these publications and some of these parts of the press finally stepping up to highlight this issue, and for us to build some kind of momentum on it. But there's so much more, to deal with data-wise, and which, of course, I could submit to you later.
I would love that. I would really love that. What do you want the listeners to know? Like, first and foremost, what do they need to know when it comes to Black women's mortality rate, when it comes to the infant mortality? Are you guys also looking at that, too? Like, how many Black children are dying? Not just the mothers, but the children of these Black mothers.
Yes, we are. Well, what people would love for people to know, what we would love people to know is that we need people to come together to support methods of finding ways to end these disparities. So what we've done is we set up a crowdfunding campaign on experiment.com. Experiment.com is like a GoFundMe or a Kickstarter for science. It's been supported by Bill Gates. It's funded by the same company that funded Facebook. It's a very legit crowdfunding platform. So all you have to do is go to bit.ly/mHealth trials, which is M as in mobile, mHealth trials. And there's a little information there of how you could support. Just add your name, your email, and what you think you could add to funding this campaign. Results would be we'd head back to Africa, where we had several doctors from here in the United States go to Africa to conduct a health mission. We saw thousands of patients and diagnosed them and conducted over 160 live surgeries in 1 week.
What?
Yes.
How'd you do it? Like, major surgeries?
Major surgeries in 1 week. I'm talking about less
Did
than
y'all
10.
sleep?
I'm talking about less than 10 doctors. And in 1 week, in very difficult conditions, not in hospitals, right there in mobile, clinical, like, vans and
Were
buses.
they sterile?
They weren't put to sleep. They were given minimum
I meant
euthanasia.
the actual unit. It's like,
No, these are fabulous doctors who are here in America, from Houston to Atlanta to Boston to D.C., flew to Africa, paid for the medicine themselves, the medication themselves, flew in with their nurses, went into the ground, on the ground in deep rural villages, and said, let's do this.
So how does that work? All right. So I'm showing my ignorance right now.
Yeah.
So when you go to the doctor and, let's say, my son got his tonsils taken out, or I had C-sections with both my children, like, the entire room has to be clean. Everybody has to be sterile.
Yes.
They wipe you down with this nasty brown-looking stuff that's supposed to be cleansing. But then now we're, in a third world country. It's not cold. It's and from what I understand, the cold kills the germs.
Yeah.
So we're in heat.
Average temperature is 95 degrees.
We do not have an OR room.
No.
We don't have scrubs.
Nope. We emptied buildings. We took emptied buildings and we went to a village and emptied some buildings and took a mobile, like a truck, right? Emptied the back of the truck, and then from there we'd have, kind of like freezing units, and then, just get the people in the room, and after you've been diagnosed and you've been set up for your timing, whatever it is, we had emergency room doctors do what they do.
Give me an example of a surgery that was conducted.
First and foremost, as you said, people had to clean the room, so I wasn't in the room for that. So you are correct. These doctors carried out as close to medical hospital procedures as possible without euthanasia, because they weren't hospital facilities in case someone really fell asleep. They didn't, so most of these people were wide awake
But they weren't in pain.
Well, they were in some pain, but they were not. They were given some pain medication, but not enough.
There was no 5-4-3-2.
That it's not a real hospital, so you can't give the person the most information, because in the real hospital you can just go to another side and bring something to pump them back up. None of those, so the people were awake conducting these surgeries.
Reggie.
It's tough stuff. You needed to do it. I mean, someone you're there, you're in time. You know this person needs surgery, and it's what has to happen. So the key now is to go back after a few months and see these people and evaluate how they've been. Take the paper documentation with their medical records, digitize them, apply them to the app, and then I would come back to America, be back with the doctors, and then give the doctors the app, download them, and then the doctors here at Harvard would monitor the communications between the doctors who went to the mHealth mission and the patients. And then we have the president of Give Inc., Dr. Joseph Slokowski, who's a pain expert, working with OBGYNs who are on our steering committee to see what are the relations between the pain and the OBGYN issues that are common or not, and then we give them to pregnant women. The thing here is that coming back to America, you could be in the middle of Nebraska and you don't have the access to a doctor in Atlanta, DC, Boston, and you kind of pay the same health care. And that's where the test. So until the industry between 2014 and 2016 is where we saw a big growth in the industry. And doctors started feeling more comfortable once Samsung brought out their mHealth app and Google brought out their version and Apple brought out their version. And all of that took place in 2014. So we're 3 years removed from that. And we've seen a lot of growth in this industry. Now, how is it being applied? And is it changing the habits of medical doctors to switch from the habits to no, overall, no. We have different issues facing doctors. For example, I'm not sure about this number. I believe it's over 400 doctors in America commit suicide every year.
What?
Based on being burnt out alone, just that issue alone. It may be 4,000, I'm not sure. But I believe it's over 400 doctors in America commit suicide every year based on the fact that they're burnt out. So these issues, and then going to a doctor who's already burnt out and say, hey, do something else. Add this to your, actually, you need to do this more or that more.
Because I know my doctor's burnt out, like just simply using the new technology that they have that allows the patient to doctor, like for my doctor to simply write me a note instead of having to call me or, just sending me an email on this new platform. I know my doctor's like, I hate this. I can't stand this. There's no way for...
Because of all the regulations that are added to that technology and all the codes they have to pass just to send you a single message. And for you to answer it, you have to do all these random things to get by. And they need to see another patient now. And it's just...
It's overwhelming.
Yeah.
So there's no way for this to be like, for the nurse to have clearance and for the nurse, I don't know. It seems so easy.
Exactly. There are ways. So what we're doing is what we first did, where, after meeting with Dr. Keith Black, is we got a group of doctors from around the country and asked them, how would they use this? So we wanted to, first of all, deal with that issue of doctors' burnout. So due to your heavy schedule, how would you schedule another 15 minutes a day for a random patient? And would that work for you? So we got different responses from different doctors on how because listen, it's very difficult for the average doctor to give an extra 15 minutes per day. So we got that understanding first and then coded that into the app.
Reggie, right now, people may not see value in the app you created, but I'm a futurist, and I see how this is going to be integrated into every hospital in every developed country. And I'm interested in knowing how many lives you actually save
I appreciate
with
that.
this technology.
I appreciate that. What we're looking to do, for the most part, is influence others. Yes, we're going to be successful. The aim is to be successful. But the reason why we're called Give mHealth, Generating Innovation, Ventures, and Enterprise for Mobile Healthcare.
Say that again.
Give mHealth, Generating Innovation, Ventures, and Enterprises for Mobile Healthcare.
Okay.
Is that we want to apply other innovators' apps to our app. We want to find funding for other innovators who may not be entrepreneurs or startup guys, but build an app that can possibly help for cardiovascular diseases or for eye illnesses or for that are just, they just built and they couldn't get investment and they're just in the middle of nowhere, now, working at Starbucks or something like that.
But I have this great idea, Reggie. How do I contact you so we can go ahead and save millions by my great idea and your possible millions of dollars that could back this great idea?
Yes. Right now we're just looking for $5 here, $20 here, $100 here, $50 here from folks who want to go and support this specific clinical trial to help find if there are direct correlations between pain during pregnancy and death in childbirth for pregnant women by just going to bit.ly/mHealthTrials.
So they can, what website can they visit?
It's on experiment.com, but the direct link to the funding campaigns, the crowdfunding campaign is bit.ly/mHealth, mHealth, trials, TRIALS, bit.ly/mHealth trials. You just go on there, you put your email address and your name, and then you click fund, and whatever amount you wish to fund with gets us closer to identifying these correlations and getting them to pregnant women here in America, specifically African American women, to decrease that rate of them being 300 times more likely to die at childbirth.
AKA 56 black women for every 100,000 die during childbirth, where white women, it's 18.9 for every 100,000. And Reggie has created an app that is currently in clinical trials in Africa in partnership with doctors here in Harvard. And I'm so proud of you.
Thank you.
I'm so excited for you. What if I do build apps? What if I do want to help with the technology? What if I can give a little here and there, but what I would really like to give is my intellectual property in order to help.
Well, we are connected to startup accelerators all over the country, specifically here in Boston, both at MIT and at Harvard, as well as the largest startup accelerator here, which is here in Massachusetts as well, here in Boston. So, we're willing and interested in connecting them directly to these accelerators and pushing their innovations forward, as well as possibly, if I have time personally, giving them little guidance on their startup presentations, because a lot of these accelerators are pretty cutthroat.
I can imagine.
Yeah.
What they're dealing with. How exactly do we contact you?
I I really don't mind giving my number here, where
Please do.
I'm looking forward to as many people to reach out as possible. 857-829-9743. That is my number directly. Our email, Give mHealth, is doctors@givemhealthglobal.com. That is, the website is givemhealthglobal.com. A lot can be seen about us there. And the email is doctors@givemhealthglobal.com.
And say your name one more time.
I am Reginald Mbawike.
Mbawike.
Yes.
I said
I
it
knew
right.
you
It
could
took
do
me
it. I
all
knew you could do it.
took me the whole hour, but I did it. I am Taylor Andre. You can find me TaylaAndre all over social media. You can contact me directly. I thank you. I love you. I appreciate you. I see Reggie's vision for this app, and for me, I'm just like, hold on, this should be in every hospital everywhere today. And you know, a little step here, a little step there. What is it? The wind blows.
The wind blows harder the closer you get to the mountaintop.
But you gotta keep climbing.
You gotta keep climbing.
I love you. I appreciate you, and I hope you guys have an amazing day. Mwah.
Thank you for having me.
Thank you for coming. Thank you, Reg.
Thank you. I didn't know I could do that.
Why?
Well, you know, you have all this information in your head, and you're wondering if it comes out when you're asked a question.
Well, I
You always
think
wonder
it
because you're just
flowed.
alone with you and your laptop. And you know, you're just like, there you go, okay, Celtics game.
Is there anything else that you wanted to add? Because we're still recording. Is there anything else you want to add? Anything else that you forgot that you're like, shit, I should have said?
I should say the names of the lead doctors.
Yeah, let's do it.
I only said Dr. Leo Grimaldi.
And
I only said Dr. Joseph Slukowski. Yeah, I don't think I know their names.
So, Reggie, is there anything else you want to tell the listeners? Is there anything else that they should know about this project?
Yes. I believe I wanted to thank the doctors who have worked so hard on this, specifically the lead doctor for the Give mHealth clinical trials, Dr. Leandro Grimaldi Born-a-Saint, who couldn't be here today. He's traveling out of the country actually today. And Dr. Esteban Gershnik, who is lead advisor. He is the head of the medical floor at Brigham and Women's Hospital. I would like to thank Dr. Hyatt, who's the founder of the Global Health Equity Program at Harvard. He's a professor at Harvard, but he's a founder of Global Health Equity Program at Brigham and Women's Hospitals for just being there. Dr. Paul Farmer for also being there, and Dr. John Madison, who is the lead doctor at Kaiser Permanente, for joining our clinical trials team.
Well, Reggie, I want to thank you so much for your innovation. I want to thank you so much for, your futuristic thinking and for going ahead and putting the greed behind you and wanting nothing more but to help your people. I definitely appreciate that. And because of that, I see nothing but success in your future.
Thank you very much. Thank you very much.
I am Taylor Andre. Waking Up with Taylor Andre has absolutely nothing to do with the time of day we link up, but about waking up your third eye with unorthodox conversations leading to universal consciousness. I am Taylor Andre, TaylaAndre. I thank you. I love you. I appreciate you. And I hope you have an amazing day. Mwah. So I'll just edit that, and this will air on Tuesday.
And Tuesday at what time?
7 p.m. to 8 p.m.
PM, not 8 a.m.
No.
Okay, great.
PM.
That's great. That's great. That's great. Yeah. Oh.
That's supposed to stop. All right, let me get out of here because I gotta go to work.
Okay.
Let's Nope, this is all signed. This is ready to go. Let me get Morgan. Thank you so much. It was a pleasure.
Thank you.
No
very
worries.
much.
I'm sorry it took so long, but you know what? I think it happened right when it was supposed to happen.
Exactly. There were so many things. As I said, the whole wind blows me. From when I was talking to you when I was in Nigeria till now, that just, and it's just like, I think the devil's trying to stop me.
Well, you know what? The devil is a lie. The devil is a lie.
This ain't gonna happen. I know it's not supposed to get easier. You're supposed to put your dukes up a little bit more.
Hold on. As the wind blows, once you reach the top, you gotta keep climbing. And